Thank you. Well, hello, everyone. I'm Mandana Khalili, professor of medicine and the director of the UCSF Research Coordinating Center's Investigator Development Unit of the NIMHD Health Equity Action Network. I'd like to welcome you to our monthly training webinar. Before we start, we'd like to acknowledge the Ramaytush Ohlone people who are the traditional custodians of this land. We pay our respects to the Ramaytush Ohlone elders, past, present, and future, who call this place the land that UCSF sits upon, their home. We are proud to continue their tradition of coming together and growing as a community. We thank the Ramaytush Ohlone community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. Wonderful. Okay, so we are today honored to have Dr. Tracy Woodruff with us. She is speaking on environmental chemical drivers of health inequities and chronic disease. Dr. Woodruff is the Allison Carlson Endowed Professor in the Department of Obstetrics, Gynecology, and Reproductive Sciences at UCSF. She's also the director of UCSF's Program on Reproductive Health and the Environment, as well as the director of the UCSF Environmental Research and Translation for Health, or EARTH Center. She's a recognized expert on environmental pollution exposures and impact on health, with a focus on pregnancy, infancy, and childhood. And she's also known for her innovations in translating and communicating scientific findings for clinical and policy audiences. She's also previously served as a senior scientist and policy advisor for the U.S. Environmental Protection Agency's Office of Policy. During her presentation, please do not hesitate to ask us questions either through chat or by raising your hand, and we'll be sure to call upon you. And also we'll have at the end of this session a period of time for questions and answers as well. Dr. Woodruff, welcome to our webinar, and we look very much forward to your presentation and your expertise.
Thank you so much, Mandana. I was really excited to accept this presentation because understanding environmental chemical exposures as a driver of health inequities is so important as an important component of addressing health inequities in the United States and globally. So as you mentioned, I run the Program on Reproductive Health and the Environment and the Environmental Research and Translation for Health Center. We focus on using research to drive solutions for healthier environments, for healthier people. And we do that through targeted research, improved clinical care, and just public policy. And I have nothing to declare. Okay, so I took this opportunity to try out this polling option that you have in Zoom. So we made a couple polls just to get a sense of people's base knowledge. So the first one, Rochelle is going to reveal it right now, is on what people's understanding is of the leading cause of premature death worldwide. And you see the answers here. It's not too many of you. You can even just say it in the chat. And I have them here. How many people have answered? Okay, well, we can actually, almost everybody. 2 more people. Maybe you have to answer it, Mandana. Did you take it, Mandana?
I did. I did indeed.
All right.
I'm not the delinquent one.
We'll do the big reveal now. It's fine. Okay. So can you see? Stop. Yeah. So I love this poll because this actually is very revealing, because I think our common understanding is that the biggest contributors to premature mortality, a lot of people think it's communicable diseases like AIDS, tuberculosis, and malaria, or other factors like malnutrition. But really the biggest driver of premature mortality globally, and this has been published in 2 different Lancet reports, is total pollution, though secondhand smoke and smoking is right up there. So I'm just going to show you, this is the abstract from the paper, but I wanted to highlight this because they've been able, we have good data to show that some factors we know a lot about, like air pollution, and we know air pollution can contribute to premature mortality, and there's good estimates on that, and that is one of the biggest contributors to premature mortality globally. But the other factors that I'm going to talk about today are other types of pollution-related diseases. So we know a lot about air pollution and lead poisoning, but hazardous chemicals, which I'm going to talk about today, which are ubiquitous and to which we're all exposed, and there's unequal exposures. We actually don't have all the data we need to really identify their contribution to the global burden of disease, but we have data to indicate it's quite substantial. And I also noticed that this evaluation of premature mortality, this is the second in a series that's been published by these authors in Lancet. And in between the two publications, they note that little progress against pollution can be identified overall, meaning we have not done, there has not been sufficient progress to reduce this very important risk factor. And it is inequitably distributed around the globe. So particularly in low income and middle income countries where pollution is most severe. So the other factor I wanted to bring up is that I think a lot of people think of AIDS and tuberculosis, for example, and they're certainly important in terms of burden of disease, but the burden of overall disease has shifted significantly since 1990. So in the 1990s, communicable diseases had the highest share of the overall global burden of disease. Almost half of the global burden of disease in 1990 was from communicable diseases. But that has shifted significantly with increases in non-communicable diseases globally. And now they are the highest burden of disease globally, which these are factors like cancer, respiratory outcomes, cardiovascular, neurological, and metabolic disease. And so it's this increase in non-communicable diseases, which I know your network is very focused on, and the health inequities, that we have to look to environmental factors as a really important driver of this shift in the diseases that we have to deal with, both as researchers, clinicians, and in the policy world. And then I want to anchor the work that we do in this excellent work that has been put out by Ibram X. Kendi, who talks about an anti-racist research, which I really find very, it's really important to the type of work both that you're doing and that also the work that we do at PRE and the Earth Center. And the reason I like this is because he quotes that racist research historically has posed the question is, what is wrong with people? And I think we see this pretty prevalent in a lot of NIH-funded research or research that we look at, which is, really focused on how do we make people eat better, walk more, exercise more. It's all very much focused on individuals' responsibility. And certainly we have personal responsibility, but a lot of the factors that are focused on are really move into blaming the victim and don't really focus on structural factors that influence people's access to high quality food, access to be able to exercise, and what I'll talk about is access to a healthy environment. The anti-research asks a different question, which is what is wrong with policies, or in this case, structural factors that that contribute to people not being able to lead their healthiest life. And so policy change is key to the anti-racist agenda, and that is what we should be focusing on is the policy change if that leads to a positive solution rather than a negative solution that improves health equity or increases health equity. And that is the focus of our research and I'll be talking about today. So what about chemicals? So this is a quote from the former director of National Institute for Environmental Health Sciences, and it's that we live in a chemical soup. And what we mean by that is we are surrounded by toxic chemicals in every aspect of our daily lives, whether it's in our food, in our water, in our air, in the many very different types of personal care products or building products or products in our home. And then certain communities live in areas which are more highly contaminated because of location near sources of pollution. So before we get more into this, it's time for another poll. So I'm just turning it to Rochelle, who's going to do another one. Okay. So before, I just trying to get your base knowledge on, before I start talking about these various factors that we focus on in environmental health. Do you know the names like phthalates, PFAS, or BPA? Okay, two people. Oh, good. Okay, people know what this is. It's kind of a trick question. Okay. Okay, great. So people have some base knowledge. That's excellent. We can keep going. All right, so the problem of these chemicals like PFAS, phthalates, phenols, or BPA found in plastics, furnitures, carpets, foam, etc., and these are just a few of them, is that they are produced in massive quantities and imported just in the United States alone. So this is data from the U.S. Environmental Protection Agency. There's 30,000 pounds of industrial chemicals produced for each person in the United States every year. That's about 9 trillion pounds of chemicals. So it is inevitable that we are all exposed to these chemicals. And in fact, that is what ours and other research shows, is that people are carrying around body burdens of not just one of these chemicals, but many of these chemicals. And the research also shows that these chemicals are at levels that are adversely influencing health, including the chronic diseases. And before, I want to talk about also to position this in the importance of the upstream factor that is driving this chemical production, and that is the connection to fossil fuels. So fossil fuels are the feedstock that makes all these different chemicals, particularly chemicals like plastics that we find in all these different products that we are using or coming into contact with in our daily lives. So and one of the factors that's really important, and it will be particularly important in terms of health inequities and environmental justice concerns, is the large increase that's happened due to natural gas and fracking, particularly in a lot of the southern states and in the Ohio Valley. And that is natural gas is used as the feedstock to make intermediate products, including vinyls, vinyl chloride, and other products. And the thing that I think people don't realize is that the production of ethylene, which is basically what's used as the building block for plastics and other types of consumer products, it's more lucrative to make that, to turn it into plastics, than it is to sell it for fuel, heat, or electricity. So ExxonMobil, which you're probably familiar with as a fossil fuel producer, is also the biggest maker of this chemical, phthalates, which is used in plastics, and I'll talk about as a case study of both unequal distributions and a driver of health, chronic health conditions. So there's a really important tie between climate change, which obviously also is increasing and is an important driver of health inequities, and chemical and plastic production through these fossil fuel industries. So just to read briefly, I want to say that there's also been an increase and also projected increase in both the production of these feedstock chemicals as well as the chemical industry overall and plastics. It's increased since over the roughly the same time change that we're seeing an increase in chronic health conditions. And that is one of the factors that professional societies have identified as linked to these increasing chronic health conditions, and that they are continued to project to continue to grow with the particularly as new facilities are being put in place to make more plastics. And just to we know there's been a lot of, we know that climate change is a globally threatening condition. And there's a group who looks at what's called planetary boundaries. These are boundaries that if you cross, put us in, they're basically, the planetary boundaries are safe operating spaces for humanity with respect to Earth systems. So clearly we're outside the planetary boundary for climate change, but recent data show that we're also outside the planetary boundary for chemical pollution. And that means that we are putting humanity in a precarious position to safely survive. All right, so as I mentioned, chemicals are used in many different products. People come into contact with them through water, air. They're used in all kinds of ways that touch the foods, whether it's pesticides or in containers that they're either deliberately added to food or in containers that they leach into food and people consume them through food, personal care products, air pollution. I also want to note that occupational exposures are very important. And so this tends to be many of communities of color and low-income communities can have higher exposures due to occupational settings, for example, farm workers and pesticides. So we focus on developmental periods of exposure because this is a really unique time biologically because of development that's happening. And because development is happening both rapidly and uniquely, perturbations that occur from external factors, such as toxic chemical exposures, can permanently alter the trajectory of development. And that can increase the risk of multiple conditions, whether it's something that's observed at birth, so something like low birth weight, preterm birth, a birth defect observed in childhood, neurodevelopmental effects, or also can be observed later in life, including cancer, cardiovascular disease, and metabolic disorders. So pregnancy and preconception are really important times because there's a lot of development that's happening during that time, and that's why we focus on that period, because if you identify factors that influence that and you set your interventions to get below those, to get to risks or safer levels for those exposures, then you therefore will protect the majority of or all of the population, because you're focusing on those that are most biologically susceptible. And we've also shown in our studies that during pregnancy, exposures are measured to dozens of different industrial chemicals. This is from a study we did long ago, but there's others showing even more, that it's not just one, but many different chemical exposures. And what this means also is that the fetus is exposed to these chemicals in utero, and the National Cancer Institute has written that to a disturbing extent, babies are born pre-polluted. So we know these chemical exposures are occurring even before conception. So I just also want to note that those are chemicals that are measured in biological samples like blood or urine. We also have good data on where people live and the sources of exposure that they can be exposed to in their environment. And I want to point out that this is a resource in California. California has been a leader in mapping both environmental exposures as well as other factors that can increased risk of adverse health conditions. So these are structural factors like poverty, food insecurity, unemployment, linguistic isolation, housing burden. And then also, so those factors can create an additional stressor, making populations more vulnerable to toxic chemical exposures, for example. And then also populations can have higher disease burden. In this case, California looks at asthma, cardiovascular disease, and low birth weight. This can also make populations more susceptible to exposures to environmental contaminants. And as an example, California actually maps the intersection or overlay of both pollution factors, so air pollution, water pollution, pesticides, water burden, with these other factors such as social stressors that can come from the linguistic isolation, unemployment, and then these sort of biological susceptibility factors that are increased disease burden. And so you can see, and then it's ranked in the state of California, you can see that there's this overlay of environmental factors along with other factors that can create populations who are at higher risk for disease burden. And they tend to be, or that those overlays are increased low income and communities of color. So this is illustrates the environmental justice burden that is happening not just in California, but across the United States. And then we also, looking at biomonitoring data, find that exposures continue to be unequal between Hispanic and Black pregnant people. This is from a study recently that we published showing that there is higher exposures among Hispanics and Black pregnant people to chemicals that are found in consumer products. So bisphenols, parabens, phthalates, and this means that there are higher levels in these populations, and there's also some higher levels in pesticides as well. So we know there's an unequal burden of exposures to environmental chemicals, and many that we know that are linked to known toxicities. And whoops, I just want to say lastly, about this topic before I give a case study, when we go through slides, is that a lot of these chemicals are also can act through different types of mechanism. There's a important class of these that are called endocrine disrupting chemicals. And these are chemicals that can interfere with the endocrine system, meaning they can alter levels of estrogens, androgens, testosterone, or thyroid hormones. And those kinds of alterations, particularly during these vulnerable developmental periods where hormones are a really important part of signaling development during fetal development and times during child development. If you expose to these endocrine disrupting chemicals and they alter hormones during these critical periods of development, that can lead to increased risk of chronic health conditions downstream. And so some of the factors that have been identified, this is from a group, the Health and Environment Alliance in Europe, and they've looked at some of the evidence around EDCs and female reproductive health. So things like early menopause, breast cancer, polycystic ovarian syndrome, endometriosis, infertility, irregular menstrual cycles. These are also health conditions that affect Black women at higher levels, for example. So it's important to think about EDC exposures. Like I said in the previous slide, those chemicals that we found at higher levels in Black and Hispanic women are endocrine disrupting chemicals, and they're linked to these diseases, which we also see higher in Black and Hispanic women. And so I remember to mention that petrochemicals, which are coming from the feedstock from fossil fuels, and particularly plastics. So we know that these chemicals particularly these endocrine disrupting chemicals, can increase the risk of many different types of adverse health effects. So I've mentioned infertility, diabetes, cognitive decline, cardiovascular disease, cancer, low birth weight, neurodevelopmental harm, immunological, and asthma. So basically all the chronic diseases, or many of the chronic diseases that are increasing and are inequitably distributed. And that the risk from these chemicals can be modified by these other non-chemical exposure modifiers. So things like socioeconomic status, discrimination, racism, nutritional status, etc. Now, I'm going to give an example of this, but I just want to note that when you see these risk factors, you'll be like, well, that's not too high. But because everybody in the population is exposed to these chemicals, if you have 360 million people exposed and you have a small risk factor, that still means that means a high number of attributable cases across the population. So that's why it's really important to understand the risk factor and the intersection between risk factor level and the number of people exposed, because environmental chemicals are a little bit different than some of these other factors because of their ubiquity of exposures. And this just shows that by having these factors add up together, you can move people from mostly no adverse outcomes to adverse outcomes. So this is if you have a distribution where a few people might get sick, but you add in factors like age, genetics, some more people can get sick in that distribution, And then as you add in other factors like stress, racism, and poverty, or food insecurities, those push people who have those conditions can be moved more into the adverse outcome side. So this is a lot of, we've seen now, particularly in the Biden administration, a focus on these cumulative impacts to really understand the totality of exposures in combination and how they adversely influence health. And so, and as I mentioned, that these toxic chemicals are taking a toll on our health in numerous and different ways. And I'm going to talk about this through the example of phthalates. So fortunately, everyone knows what phthalates are, but I'm going to talk about them again. These are a class of chemicals. And if you're interested, here are some of the famous ones down here. They are manufactured small molecules that are made to, I don't know if they're primarily, but they're largely used in plastic applications. So they can make hard plastic more flexible and bendable. So you see them in a lot of different types of plastics like medical equipment or coatings of pharmaceuticals. They can also be in art supplies. A lot have been used in building materials like vinyl flooring and wallpaper. You also can see them in baby products. They also have a property where they convey scent. So a lot of scented products have phthalates in them, like cosmetics. This is probably just plastics, but also scented products such as candles, detergent, and air fresheners, lotions, shampoos. So they're used in many, many different applications. So we are going to be exposed to them because they're used in so many places. They don't, they get out and about from these applications, and then we are then exposed to phthalates. So what we found is that 100% of people in the United States have some levels of phthalates in their body. This has been true for decades now. And phthalates are known endocrine disrupting chemicals. Phthalates disrupt androgens and testosterones, meaning that they block the synthesis of testosterone. So higher levels of phthalates mean lower levels of testosterone. And testosterone is very important, particularly during development, for male reproductive development during the fetal period, but is also an important hormone for other types of risk factors. So there's been a lot of studies on phthalates, and it has been shown that phthalates are known or likely to influence male reproductive toxicity, so affect sperm and this measure of male reproductive development, which is decreased anogenital distance. There also can increase the risk of preterm birth and metabolic disorders, including insulin resistance and diabetes. So they're also suspected to increase the risk of spontaneous abortion and neurodevelopmental harms. Again, these conditions are all have been increasing in the United States over the last 20 to 50 years. Phthalates, as I showed previously on the other slide, and there's been other work on this, are inequitably distributed. So Black women have higher level, in various studies have measured the difference between phthalate exposures using biomonitoring data between Black women, white women, and Hispanic women. And in general, Black women have 30% higher exposures to phthalates than their white counterparts. And there has been work identifying that some of this is due to beauty-related products. And I just want to note that these this is work that is done by Ami Zoda, who's at Columbia University, and that some of these beauty products are specifically marketed using somewhat racist marketing practices to try and encourage people to use these products to either mask, quote, mask odors, or have, like, for example, look more essentially similar to their white counterparts. And so this kind of racist marketing practices has the downstream effect of leading to higher exposures to certain toxic chemicals. And this is from a study, and I think this really illustrates why chemical exposures matter for health inequity. So here's preterm birth. Preterm birth is inequitably distributed. Black pregnant people have higher rates of preterm birth than their white counterparts. It's well documented, is historically the case for decades. So actually one of the reasons why I got interested in this type of research was trying to figure out what is it that might be driving this that's not about people, but about the environments that they live in or that they're exposed to. So this is from a study. It's a pooled study of 16 cohorts. So there's 6,000 pregnancies in this study. They pooled cohorts from across the United States where they had measured phthalates during pregnancy, and then they looked at the relationship between phthalate exposures and preterm birth. And what they found was, so everything on this side is positive relationship between phthalates and preterm birth. Everything on this side is no relationship. So you can see, and there's adjusted and unadjusted results. You can see that there is a pretty consistent relationship between phthalate exposures and preterm birth. And when you look at the phthalates in combination, because also the science indicates that exposures in combination have a greater effect than individually, you can see that in combination that that there's a higher risk from combined phthalate exposures than individual exposures. And in a second paper that was published, you can also see this is the distribution of exposures by race and ethnicity. So these are different phthalate names here. The orange is Black, the purple is Hispanic Latina, and the green is Asian. And this is in comparison. They did a what was the percent comparison between this group and their white counterpart. And you can see that the Black participants had higher levels of these phthalates across the cohort, and also so did the Hispanic participants, Hispanic Latina participants, and it was up to 148 and not up about 148% for the Black participants higher and 94% higher for the white participants. So the next thing that was really interesting about this study was they then said, well, they did this intervention scenario saying, what if we reduced the disparities in the phthalate exposure? So we took the exposure in the Black participants and lowered it so that it was the same level as the white participants. And you can see after they did that hypothetical intervention to reduce health inequities in the exposures, that they showed that you would reduce the health inequities in between the relationship between the phthalates and the preterm birth you would reduce the health inequities that occur between their risk factors. So here is before the intervention. You can see that there's the difference in preterm births is in 15, and then after it goes, the difference between here and here is 15, so that you get a reduction in 13%. And not quite the same with Hispanics, but the point being that the hypothetical intervention removes the disparity in the phthalate preterm birth relationship by taking away the phthalate exposures. So it shows that we can reduce some of the inequities by reducing inequitable distributions of exposures. Okay, so I want to talk a little bit about the strategy that we use to use our research to motivate positive actions to reduce both harmful exposures, but also inequitable distributions of exposures. So I have said, like this cartoon, because it says, I'm afraid there's not much I can do for you now. You should have come in sooner before you got sick. So our strategy is all about how do we have prevention and to stop people from going to have to go and have an intervention that not that we, of course, you have to have clinical treatment and for people who are sick, but our ideal is there'd be less people going to the doctor in the hospital by being sick because we stop them from going there because we mitigated their harmful exposures. So as I mentioned, our strategy is we work collaboratively across the UCSF campus, integrating basic science, exposure science, and epidemiology. We focus our research questions on data gaps that are key to answering key questions that will help us move systemic actions to prevent harmful exposures. And we do that by working with healthcare leaders and public policies. And our goal is to improve health of not only infants and children, but all populations. So some of the work we do is we work with health professional societies. This is work we've done with the American Congress of Obstetricians and Gynecologists, American Society of Reproductive Medicine. But until our engagement with them, they didn't even recognize that environmental exposures were important for reproductive and developmental harms. So through our active engagement with ACOG, and this is the professional society that represents all obstetricians and gynecologists across the United States, they issued a committee opinion that said that that environmental factors are a very important risk factor and consideration for clinicians when they're looking at reproductive and developmental outcomes. And importantly, they also wrote in their committee opinion that exposures are not equal. And they noted that underserved and communities of color have higher exposures due to environmental racism, and that occupational exposures are also very important. So the strategy is that once clinical societies recognize this as an important risk factor, they continue to be important advocates on behalf of their patients. And this is then went on to work with the International Society of OBGYNs, which is called FIGO, and they issued also a consensus opinion saying that reviewing the science, and their recommendations are to advocate for policies to prevent exposures to toxic environmental chemicals. And this is really important because FIGO represents OBGYN societies, over 130 around the globe, and they are for many countries the go-to source of information for clinical activities. And it's really important that a clinical society is saying, yes, it's important we deal with this at the individual level, but really on behalf of our patients, we need to promote public policies to create equitable and fair solutions to reduce all exposures. They also note that their recommendation is to work to ensure a healthy food system for all, make environmental health part of healthcare so that clinicians recognize this as a risk factor, and to champion environmental justice. So I think this pretty much sums up the work that we also do to have an integrated approach to addressing health inequities. And I want to lastly finish by talking about, as I noted, that we've seen a shift from non-communicable diseases from communicable diseases to non-communicable diseases or chronic diseases globally in terms of being the largest burden of global disease. And certainly that is the case in the United States. And I've talked a lot about chemical exposures as well as fossil fuel contributions to this inequities. But I also note, and a lot of people pick smoking as the biggest risk factor for premature mortality. But there's all the other factors that have been increasing we have to contend with as exogenous risk factors, including ultra-processed and fast foods, pharmaceuticals, and other types of alcohol. And all of these products are products that are produced by industries or corporations. So corporations are producing risk factors that are leading to these chronic diseases that we're seeing reflected in our society. So, and this is from also something that was published recently in the Lancet, that it's estimated 50% of all premature deaths globally are due to corporate produced risk factors. That includes tobacco, fossil fuel pollution, alcohol, processed and ultra-processed food. So what this means is that if we are going to address chronic diseases and inequitable distribution of chronic diseases, we want to go upstream, we have to address these risk factors which are being produced by corporate entities. So one new area of work that we have been doing at UCSF, which has a lot of people who work on commercial determinants disease, is looking at the industry as the 21st century vector of disease. So in the 1990s, when we had communicable diseases, vector of disease was communicable illness. So those were living organisms that carry and transmit an infection pathogen to one organism to another, when they tend to be blood-sucking. So, like a mosquito. But now we have the illnesses of most or highest burden are non-communicable or chronic illnesses. And our disease vector is really corporate organisms that they are transmitting toxic environmental exposures, like McDonald's, for example. So I think we have to our goal here is to shift our thinking about who are the actors, the corporate actors, that are contributing to these risk factors that are increasing these chronic and inequitably distributed diseases. So the increasing non-communicable disease is a manifestation of a global economic system that prioritizes wealth creation over health creation. So actions. So we're all about systemic change. I want to say we can do this. It is possible to do it. The US did ban certain phthalates it was in toys, but the downstream effect was that manufacturers took phthalates out of a lot of different products. These are the levels of certain phthalates that were banned in the US population. It's measured by CDC and biomonitoring studies. In 2001, it was up here. After the ban, it went down to here. So it shows that public policies to ban chemicals can result in reduced exposures to toxic chemicals. There were some phthalates. There were also the targeted marketing campaigns by non-governmental organizations, including the Breast Cancer Prevention Partners. That also led to a decline that got out of the products, decline in exposures. So manufacturers still making plastics, and they use a different kind of phthalate, which we saw going up. So while we've been very successful, we continue to focus on these bans, we have to also think about comprehensive approaches to reducing these chemical exposures. So one other thing I want to say is it's really, this group sprung up during COVID, but we always recommend people vote. It's really important people to register and vote. There's actual organizations of clinicians who focus on using the clinic as a place to engage with their patients to get them to vote, and they have a whole set of materials to make that happen. And then I want to also say that we organize a Science Action Network, which provides opportunities for people like yourselves to engage in policy changes when, it's a little bit challenging to think about how am I going to go and take on government or advocate for evidence-based policy changes at government agencies. So we provide a network where people can engage on activities related to policy change that share research, but also have opportunities for either public comment, blogs, or sign-on. So you can sign on here and join our group. So I'm going to conclude and thank Mandana for inviting me to speak to you. Environmental chemical exposures are ubiquitous, and they adversely affect health inequitably. And the most effective way to address this is through systemic change. And that requires scientists, along with other partners, NGO, health professional societies, to advocate on behalf of the public. And it takes time and persistence, but it is possible to make these changes. So I encourage you all to do that. I want to thank everyone, and PRE and Earth and our funders. And if you would like more information, you can follow us on all our media channels. So that, I think it's time for questions. Oh, I'm going to stop sharing because that.
Perfect. Thank you so much, Dr. Woodruff. That was an outstanding and comprehensive presentation. And I really very much appreciate it. I'm sure the audience did as well, the focus on action, because oftentimes we investigate and we may not necessarily know how to go about making the change. So thank you for all those recommendations. I'm wondering if there's any questions from the audience. I'm going to wait for a few seconds. Okay, if not, maybe I can start off by asking you a question. I was so incredibly impressed with the breadth of various exposures that exist, and also the intersection of, as you clearly laid out, the exposures, the risk factors, and then and potentially the synergistic effective consequences of those negative outcomes. For early stage investigators who may potentially want to be really entering this field and thinking more deeply about these intersections, is there a recommendation about a framework that you feel is an ideal one to focus on, and also thinking about the across the lifespan type of exposures as well?
Yeah, that's what's interesting about this has been kind of a little bit of an explosion of frameworks on this topic recently. The National Academy of Sciences discussed this in a report I mean, it's a report to EPA on the future of environmental health research, but in there they talk about framing this around cumulative impacts, which discusses how do we think about social factors, or like, I guess I would call them, I don't know if they're social factors, but the factors, social stressors, as well as other structural factors that can increase risks along with environmental chemical exposures. Rachel Morello-Frosch at UC Berkeley has also published some frameworks on this, which I think cover a lot of these topic areas. And the National Academy of Sciences has a new committee they're forming at the request of EPA to give EPA guidance on how should they address cumulative impacts. So that's going to be happening in the future. You can sign up to get alerts from them. They're going to be having 2 public workshops. So there'll probably be a lot of frameworks presented there.
Fantastic. Another potential question about engagement in this type of work is when thinking about either implementation work or clinical trials, for example, is there any particular recommendations you have with regards to various avenues to follow? Go ahead, please.
Yeah, so NIHS actually has a National Institute for Environmental Health Sciences has a big emphasis on implementation science. So they have a lot of materials on their website about implementation science and environmental health. Our center has been doing a little bit of this. The Earth Center has also been doing a little bit of this. I think there's different ways to do it. Some of them are, I've seen studies do individual type activities where they work with a patient population and, for example, randomize them into different food groups, like, oh, you eat this type of, you're going to maintain your diet. This group, you can, we're going to introduce more organic fruits and vegetables or less processed food, and then measure the difference between the two. That's kind of one way. I think what's really interesting about the study I presented on the phthalates was they did a hypothetical intervention, and I've seen a number of different studies. We actually just are publishing something like this on fluoride, where they look at the exposures and then say, well, what if we remove the exposures? What would the resulting health improvements look like? And to me, that's super helpful because that feeds right into when EPA is looking at, as part of their rulemakings or regulatory rulemakings, they do that kind of scenario situation for doing the benefits and costs of different regulatory options, which we saw with, for example, they just released a rule on ethylene oxide, which is a sterilant coming out of facilities that are more highly prevalent in Black and Hispanic communities. And they looked at, well, now that we implemented this rule, who will still be left at risk? They did do a lot of reductions. The communities that are still at highest risk will still be Hispanic. So you can see you can do these kind of, if we did this regulation or we did this intervention, who would get, and you can do that with existing data. So in that case, they use emission inventories to they model like what happens if we change the emissions from these facilities, what's the benefits going to be. So I feel like, well, that's kind of what I know about. I do less of the first one and more of the latter.
Those are really useful for policy briefs.
Yes.
I mean, those are kinds of things you can take to legislators and say, okay, here's the impact on your constituents if we were to eliminate this. Here are the health benefits. Like that's a great way to communicate.
Yeah, and I mean, when I saw the phthalates paper, because I knew they had published the preterm birth, and I know that people were doing it, and I was like, oh, why'd you do the race thing? And then they published that other one looking at, oh, here's what happened if we reduce it. It is super compelling. I'm like, oh, maybe we should do that. We haven't really done that very much, but now we've done more of the latter, like, oh, a policy happens. What was the change in exposure? But it's much better to do it forward so you can inform the actions that the legislature is considering. So yeah, I agree with that.
Absolutely. One additional question, since I have your expertise here, we've been very much focusing on taking advantage of the All of Us program. And yes, and as we were looking through that, I know that there was emphasis at some point in inclusion of environmental questionnaires. I'm not sure if that happened or not, and also if you're aware of some work in that area.
I'm going to recommend a different program, which I was
Please.
involved with for a while, which is the ECHO Consortium, Environmental Influences on Child Health Outcomes. So we were part of that consortium during the development of it in the first 6-7 years. So that's a cohort of pregnancies and children across the United States, about 40 or 50,000 children. We did, and I don't know if they're going to keep it, but we did a lot of work to include environmental questionnaires related to environmental exposure factors. And that data I presented showing that Hispanic and Black pregnant participants had higher levels of these different types of chemicals, that came out of work that we did with ECHO to have them do biomonitoring. So there's going to be data, and they actually have their data is all, or is being made, it's online, is being continuously made available online. And so you can also access it through their data portal, and all the biomonitoring data, which there's, I think up to 15,000 participants had biomonitoring data on over 100 chemicals, will also be made available. So there's going to be a lot of opportunities to look at these racial inequities and other social stressor factors. It's also geocoded, so you can look at factors, place-based factors as well.
Thank you very much. I just put the link as well. Yeah.
Okay. Yeah, I haven't gone on to try their online portal, but I know they've been making a lot of their data accessible. So I feel like that's, I don't think it's been linked to all the environmental type of data. So I think there's a lot of opportunities in there. I know all of us has stuff, but I feel like their biological sample collection was kind of limited, but I'm not that.
And I, from what I learned, it was a more recent sort of addition of a questionnaire. So there may not be even additional data to,
And they don't cover pregnancy that well, or children.
Sure. Any other comments? Well, if not, again, it was such a pleasure to learn from your expertise and have you speak with us. We really very much look forward to ongoing interactions and learning from your programs as well.
Yes, thank you.
Bye, everyone.
Bye.
Bye.